In your experience, what does it mean to thrive with AML?
I think that's a really great question, and I'm glad you're asking me now, and as opposed to a decade ago. In the last several years, we've had a tremendous number of drugs that got FDA approved, and a lot of exciting clinical trials that have not only shown efficacy and safety, but really some long-term responses. So we can now focus on not just finding what drug can work, which used to be our problem 10 years ago, since we had very limited therapeutic tools, meaning treatments. We now have several treatments available. So when I think of what it means to thrive, it's identifying the right treatment for each individual patient with acute myeloid leukemia, because what might be recommended for one patient may not be the right for another. And there are many different patient and disease-related factors that go into that decision-making.
Can you walk us through the classes of treatment that are considered when choosing an AML treatment approach?
Oh, yeah. So in terms of the different classes of treatments, I would say we think of probably three broad categories. Four broad categories. One would be intensive chemotherapy, and that involves generally hospitalization. Another would be less intensive therapy. That could involve a mixture of inpatient or outpatient therapy. That could also include targeted therapy. The third would be clinical trials, which can include any of the former options I recommended, but they would be in an experimental study. And the fourth would be focusing solely on supportive care or hospice for patients that are too sick to receive therapy. Other aspects that are specific, such as pills versus IV versus the role of transplant, I don't see that as being separate. You don't go right to transplant when you have a diagnosis of AML. You have to be in remission. So transplant, for instance, would come after an intensive therapy or after the less intensive chemotherapy. So I see that as being the second step once I choose the right treatment option for the patient.
And when you talk about transplant, you're talking about stem cell transplant, right?
Yeah, stem cell transplant, bone marrow transplant, they mean the same thing. We recruit stem cells from donors that are related or unrelated, and we mobilize them from bone marrow to blood. And so we can collect stem cells either from blood or bone marrow at this point. So that's exactly right. Mm-hmm.
And what about targeted therapy?
We have targeted therapy available that's IV or pill form. And so any one of these options can be considered. But everything is very patient specific, and I'm very happy to tell you some of the categories and nuances of things I look at, because I don't usually just offer patients a menu. I tell them what's appropriate based on their patient characteristics, meaning what their liver function is, their heart function, their history, medical history, what their labs show. And then I look at their disease history. We are now in the era where we have options. So I look to see, are there mutations that are targetable? Are there not? Are there markers on the surface of their leukemia cells that suggest that there's a target for an immunotherapy? So we don't offer classes per se without it being specific. So I always look to see what is the patient disease specific characteristics. And then I start the conversation about what the potential options could be, and then what I think the best option would be for that particular case.